Demand avoidance phenomena, or otherwise known as pathological or extreme demand avoidance, is it a disorder at a lower diagnostic threshold by Richard Woods, a PhD student at London South Bank University on the 20th of July 2021. Quick introduction is this talk shall be covering how DAP is viewed as an ASD, outlook the other three main schools of thought on DAP, and a brief overview of what a disorder looks like in modern literature, and also a brief overview of DAP and and Autism History, followed by what the extreme demand avoidance questionnaire is and how important it is in the DAP literature, and then when DAP becomes pathological demand avoidance, I mean, at what threshold? So yes, there is a main discourse around DAP that it either calls it pathological demand avoidance or extreme demand avoidance. It was originally viewed as being a pervasive dementia disorder. More recently, it's viewed as a rare autism profile subgroup or subtype. The language is, as long as it's grammatic, is essentially an autism subtype, and it's argued to have different strategies that are different to those practiced in autism. Yeah, if one subscribes to the main that discourse and respects the opinion of its leading expert, um, we really shouldn't be having this event, or I should not be doing my PhD, because I should just be accepting that this is autism and conducting research that supports that outlook. Um, so, moving on to the other three schools of thought on DAP in the literature. So, the first one is that DAP might be a common mental health disorder. The second one is that DAP is just rebranded autism. So that just means that it's pathologized aspects of it's pathologized features that are seen in autistic persons that are not covered by an autism diagnosis. And the last main outlook on the topic is that DAP is a pseudo syndrome that represents the it's a pseudo syndrome that represents symptoms that result from the interaction from autism with various co-occurring conditions. I do need to point out this is where I have a conflict of interest because I'm advocating for that to be viewed as a common disorder while earning income from that training and stuff. So, yeah, the reason why I have a conflict of interest on the topic is because I don't think DAP is clinically needed. This is just a quick overview of how app can be viewed as a pseudo syndrome made up of features from various accepted constructs. So the point to quickly note on here is that that has features of ADHD, oppositional defiant disorder, and conduct disorder, and anxiety and trauma. Autism is the other one as well, but mainly interesting on the two on the right hand side for a point later on. So what's quite important is that there are multiple behaviour profiles on DAP in the DAP literature, and there are also multiple diagnostic thresholds in the DAP literature, and there's substantial variation between them, what threshold someone gets a DAP diagnosis on. For example, the extreme demand avoidance questionnaire doesn't require the behaviours to be pervasive or from early infancy, while for example, the eating a weaver requires it to be pervasive in nature and to be from early infancy. So it's just something to be aware of. These are the core app traits, which are anxiety-based, restricted and repetitive behaviours and interests. If the trait is universal or not is based on statistics from Elizabeth Newton's original research. I'm currently in the process of trying to neutralise the language based around DAP to make it less derogatory and less problematic. So what they have is avoidance of today's demands, comfortable role play, and pretense. But this needs to be viewed as a coping strategy to a demand. The other one is consistent mood swings and impulsivity, frequent intense actions, and social avoidance behaviours. So this is an image from the PDA Society, which kind of just shows how some persons with that will show quite will show certain kind of avoidance behaviours to a particular kind of demand or stressor, and they will tend to kind of escalate in kind of uh, how difficult they are for kind of other persons around the individual to kind of manage or deal with. So you kind of got from kind of distraction to excuses going all the way right through to full on kind of panic, like self harm, shut down, and kind of running away. And they can escalate quite quickly, and they can skip various steps. Um, so for me, I view DAP to be about stress management. And yeah, moving on to the next one. So this is the demand management cycle, which is partly based off some research by Elizabeth O'Nions, but also partly inspired by the OCD cycle. Um, this is essentially a generic negative reinforcement cycle that is seen in the mental health literature. So what happens is that someone will experience demand, have some kind of anxiety or distress, and then they will express some kind of avoidance behavior or feature, whether it be rational or rational nature, um, and they will get some temporary relief from the anxiety, distress from demand once the avoidance behavior or feature is of sufficient kind of intensity or severity to kind of force the demand to be withdrawn away or removed. That's how it's negatively reinforced. Moving on to what this disorder looks like in kind of autism and DAP history. So, according to DSM-5, which is one of the main diagnostic manuals, this is what a modern disorder looks like. It is heterogeneous in nature with porous boundaries. Most disorders have features that are overlapping with other disorders, and they're kind of spectrum in nature, similar to kind of the autism spectrum. It is possible for disorders to have conflicting evidence over which diagnostic groupings they best fit into. So this is why I kind of mentioned ADHD and oppositional defiant disorder and conduct disorder, because there's a strong case for placing ADHD in with a diagnostic grouping which oppositional defiant disorder and conduct disorder are placed within, which is a disruptive impulse control and conduct disorders. Presently, ADHD is in the neurodevelopmental disorders with autism. So yeah, the DSM-5 is quite clear that it's no longer sensible to strive for homogeneous subtypes within disorders. They have quite good reasons for this. The DSM-5 is also quite clear it can be quite problematic in clinical practice to work out when a distressed behaviour or a feature becomes pathological in nature. So most disorders have a generic term in there, which is a disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. And this is quite important when you kind of consider when DAP features become pathological and a meet definition of a disorder. So, yeah, uh, it, some leading DAP experts will often compare DAP's kind of history to autism history and say it's like 40 or 50 years behind autism. But they don't really stop to consider autism history and what its implications for that. So, so for autism, it used to be viewed as a form of schizophrenia, and it used to have quite low prevalence rates, from like 1 in 2,500. And now its prevalence rate is about 1 in 100. Some people can put the prevalence rate to be a lot higher, to between 2 to 3% of the population. And as a result of this, autism has brought it into a spectrum or a continuum or a manifold kind of construct within how you kind of diagnose it anyway. And this is what I'm going to go down onto by autism spectrum disorder level 1 to level 3. So what I mean by this is that this is for specifiers of levels of support. So level 1 is just requires support, while level 3 requires very substantial support. So some people would kind of equate level 1 to kind of Asperger's or high functioning autism. The research literature on subtyping autism is quite clear that it is now accepted to be indistinguishable differences between autism subtypes and the strategies that they require. So, and research also has failed to show the significant differences between Asperger's syndrome and high functioning autism. So they're essentially equivalent. So what this kind of tells us is that autism history kind of confirms that DAP can change diagnostic groupings and diagnostic conceptualization, and it can be significantly broadened. So if you look at DAP history, at its original inception, um, Elizabeth Newson did not view DAP to be a form of autism. She originally placed it in her own created diagnostic grouping called pervasive developmental coding disorders. I don't have time to go into explain the full meanings of this diagram. It's just important to note that Newson put DAP in her own newly created diagnostic grouping, and it was used between 1986 to 1996. Yeah, she was quite clear from her first article in 1983 to her 2003 article that that DAP is not a form of autism, and she said would be a mistake to view it as such. More recently, Liz Nyers on a PhD thesis said that she encountered persons with kind of like milder presentations of DAP compared to Elizabeth Newson's descriptions. This kind of matters because Christopher Gilberg in 2013 also predicted that DAP is a common mental disorder, and that it's potentially a new disorder as well. Yeah, there are multiple studies showing that DAP is seen outside of autism, i.e., in non-autistic persons. There's about 10 that show that, and there's 2 studies where it's probable that the person, even in a case study or case of Stuart et al., it has a significant minority of non-autistic persons in there. And another point is that many experts have also stated that DAP is seen in autistic persons. So there's quite a strong case in the literature that DAP is seen outside of autism, but it just doesn't get discussed much. The EDAQ is important. It stands for the Extreme Demand Avoidance Questionnaire. It's a 26-item observer-rated screening tool designed for use with autistic children and young persons with DAP traits. If one actually considers the actual the sample in the EDAQ validation study and the actual methodology with it, there's a good case to view it as having non-autistic children and young persons in there. There's essentially no reason to view the sample as being entirely autistic. So yeah, and also the EDQ threshold is not pervasive developmental in nature. So it's also quite important because if one considers the clinical arguments around DAP for its clinical needs, they're also applicable at lower diagnostic thresholds, such as protecting persons from receiving reinforcement-based approaches and to have appropriate strategies, for example. The other thing to point out is that DDQ is commonly used in DAP diagnoses, so it's not exactly something we can just easily ignore because of that. Also, pertinently, DDQ is used in a substantial amount of DAP research. So a lot of our knowledge base is dependent on this tool. The implications of this and it being commonly used in diagnostic practice is that it is unwise to substantially deviate from this threshold. From a knowledge perspective, it means that we cannot generalize the knowledge base onto different populations if the diagnostic threshold is substantially different from the EDQ threshold. From a clinical practice perspective, if you go substantially higher from the EDQ threshold, you risk stripping support packages away from persons who have been diagnosed with it or diagnoses are kind of dependent on it. So yeah, what we're getting to here is at what point does DAP become pathological in nature, and when does it basically meet the definition of disorder according to the DSM-5? So DAP as itself presents a continuum within the human population, and it's kind of fluid and transient over lifespan and diverse situations. So what this means is how it presents an individual person changes over time, and depending on what situation they're in. So, as I said previously, most disorders will have this phrase in there which says the disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. So, if one applies this threshold for something that becomes pathological to DAP, it would be equivalent to to kind of health psychology's rational demand avoidance group. So basically, when a child or young person starts to display avoidant behaviour and challenging behaviour in response to a particular stressor, I'm not particularly happy with the rational demand avoidance term by health psychology. I think it's just arbitrary, and I don't think it's a particularly strong case because if one considers it, many of the children and young persons in that rational demand avoidance group cannot rationalise demand avoidance due to either and the other point is that a person can show avoidance behaviours to multiple stressors, so therefore not just in one context. So yeah, it's a bit of an issue. I'd also point out that something that would count as pathological either around the EDQ threshold or when something becomes problematic demand avoidance. Yeah, this is the last slide of the talk. So yeah, I think going forward we need to respect the opinion of most autistic persons that we do not want to have autism as a entity to be divided. DAP itself is quite clearly not autism. Can we please stop pretending that it is? And can we also recognise that non-autistic persons with DAP have equal rights to diagnosis, research and support, which they should do on an ethical and moral basis. And also, if you're going to invoke kind of universal rights under the certain UN kind of conventions, yeah, we also need to systematically investigate different outlooks on DAP. So, such as can it be viewed as either an attachment disorder or a personality disorder? And what I mean by this is to actually conceptualize them as an attachment disorder or a personality disorder and test it. Yeah, and also please take part in my PhD studies. So the last slide is just my contact details, so like my email address, my Twitter handle, and my ResearchGate profile, which has all my kind of publications and conference talks and stuff on. The next is just literally just my reference list. So first one, second one. I'm gonna give a few seconds on each of the references. On each of the slides the references on, just to give people time to kind of look at them and kind of pause it if they need to. And that's the last one.